Hey Drew, how you doing?
I'm well, and yourself?
I'm doing well. I'm doing well. Thanks for joining me. And good afternoon, everyone. It's great to be back here in 2022 doing our IG lives, and I hope everyone has this year's off to a great start. Now, I know that constantly changing COVID guidelines, they're keeping everyone's quarantine status, all these things, keeping everything straight, has everyone at their wits' end right now. But I still wanted to take a little bit of time to talk about influenza-like illness, because this has always been a time of year, even before COVID, where healthcare professionals are inundated with patients with a variety of symptoms, from sore throat to congestion, excessive fatigue, and right now, especially, physicians' clinics and offices are inundated. They're beyond capacity. They're short-staffed. So, what can we as ATs do to kind of appropriately triage these patients and expedite appropriate care? And with us today to help answer those questions is our good friend, Drew Duckett. For those of you that don't know Drew, he's an athletic trainer and adjunct faculty member at Boston University. Hopefully I get all of your roles right here, Drew. He serves as Associate Director of Healthcare Emergency Operations, and he's also an Associate Head Athletic Trainer. He has a area of clinical interest and specialty in primary and emergency care, and he's been integral in writing university as well as league protocols in sport participation and environmental conditions. Did I miss anything there?
I think you did well.
All right. So just tell us a little bit about, just take us through what your role is. Kind of tell us what you're doing now at BU.
Well, first off, Josh, thanks for having me, and I appreciate being back on the platform. I think the last time that we spoke, we were talking about heat illness, and
yeah, it's a little different now.
How quickly time goes, considering it's 20 degrees outside, right? Still an important topic and something that'll be back in the forefront in a few months. But yeah, I'm really excited to talk today on influenza-like illness, and sort of really any type of illness that our student athletes and our patients, regardless of what setting we're in, really have. So a little bit about my job now. I've worn many different hats during this pandemic. At the start of 2020, we, just like everybody else, took a pause to figure out what the heck was really going on. So put a bunch of resources together and figure out how we could, as a campus community, move forward with COVID-19. I then moved on to helping set up and actually direct and run our 5 COVID collection clinics that we collect PCR tests from over 40,000 folks, faculty, staff, and students a week here at BU. And then also begin to also continue with patient care, specifically in areas of illness. I think the biggest piece of my job right now, or the piece that takes the most amount of time, is sort of serving as a infection preventionist, if you will, collecting all the data across campus, across Boston, and across wherever we are, to make sure the information that we have is up to date, and whatever we can do to prevent our student athletes, whether they be varsity club or our ATC student athletes here at BU, from either contracting COVID, returning to play following COVID, or just being as healthy as we possibly can. So that's sort of the role that I'm serving now.
Yeah, and it's great as always to see athletic trainers heading up these different settings, right, and taking on all these different roles. So I don't know how you're overseeing all of that, but it goes to you. Now, I guess what kind of caused you to develop such an interest in primary care? Because I feel like it's an area that's kind of like a black box when we learn about it in school, right? It's like, this is gen med, these are your conditions, this is, maybe how you do a quick eval on it, but largely it's easy to refer it out, right? For all of us. So kind of how did that develop for you, and how has it changed the way that you practice?
Well, it's really interesting, because when we look at it, you're absolutely right. How many classes or courses do we have that specifically talk about orthopedic examination and treatment, compared to one class in gen med that may have been a 3-credit course, right? But I want to go back just for a second in terms of using the term primary care, and what primary care to me actually means. I think that I used to use that term specifically to mean general medical conditions, but athletic trainers are so much more than any specific a provider for any specific condition or type of pathology that patients have, right? So when I think about primary care, what does primary care really mean to me? And it's all encompassing term, just like a primary care physician, family medicine physician would be your primary, or other primary care colleagues that would be whether NPs or PAs or other mid-level providers. So when we start looking at primary care, we think, oh, there's a little bit of orthopedics in that. There's a little bit of neurology when it comes to head injury and concussion in that. There's a little bit of long-term illness in that. And there's a little bit of prevention and care that comes from all of that as well. So I think that was part of it, just really taking a step back and saying, not only does the practice analysis say that we should be able to be competent with injuries, but also illnesses, right? And so I think that was the starting point. However, there was one time in my career early on where I actually had a near miss in terms of the fact where an omission of mine potentially put a patient in a precarious spot for a bad outcome. And thankfully, thankfully that outcome was still a good outcome, even though I did everything possible to make it a bad outcome. And so just having that reflection and that reflective practice said, no, this is an area where I need to learn and grow. And as I decided to do that and channel all of my professional improvement and personal improvement, I put all of that into this area, and I've continued to find joy in that.
Now, what kind of resources have you used to foster that? Has it just been like journal articles? Has it been just collaboration with other healthcare professionals?
So I think it's a combination of everything. I think there are tons of online resources that are available. I think starting local with the resources that were available to me there, in terms of just what sort of interprofessional practice can I do? What sort of stuff can I talk with our team physicians and our other primary care providers on campus? Become really integral and work with our primary care department very closely in terms of seeing patients in our in our clinic here. But also, yeah, absolutely, journal articles and seeking out those opportunities to do professional development, whether it be at conferences and looking at different conferences. I mean, trust me, just as anybody else, I love to go to NATA and I love to go to CATS in Vegas. But looking at college health and looking at regional conferences that really focus on healthcare providers who provide patient care to the population that I provide care to, and that primarily is the college health student.
Okay. Now I want to kind of go through your thought process a little bit. Okay. So let's say a patient comes to you with symptoms like we've talked about: congestion, sore throat, fatigue, etc. Right? We know that there's a myriad of possibilities on what it could be. Like your differential list is like a CVS receipt. So there's tons of possibilities, equally as many treatment plans. So can you take us through kind of your decision-making algorithm, step by step? What could this patient have, and what are you using to rule things in and rule things out?
Sure. I mean, I don't think we have enough time to crawl inside my brain and figure out exactly what's going on. I don't even know half the time what it is. No.
No. We don't go that far, Drew.
No, I agree with you. I think there's two things that are really important when folks report to the athletic training room or call their athletic trainer on the phone and say, hey, I don't feel well. What should I do? Historically, and I can speak from my experience and also from some of my other colleagues who I've spoken to, historically what would happen is a patient would let me know what their symptoms were, and I would open the cabinet, unlock the cabinet, open the cabinet, and figure out which of the over-the-counter medications I had that was anti whatever they said they had, hand it to them and say, let's go, right? And I think that it was sort of this realization that I'm not doing this with any orthopedic injury that walks in, or I'm not doing this when somebody walks in with a head injury. I'm doing an evaluation to determine what type of head injury it is. I'm doing an evaluation to figure out exactly what type of injury that we're dealing with before we develop a treatment plan and before we even get to medications, right? But so slowly realizing that aspect of the way that I was treating patients might not have been the most effective. So that was the first thing, is just to make sure that I wasn't just handing out medication to folks or suggesting medication to folks without a true diagnosis. Somebody says, I have a cough. Okay, here's a cough suppressant, right? But what is actually causing that cough? Is it long-term asthma that they have? Is it something that we can mitigate somewhere else? And I think that was a inflection point for me to say, no, I need to change the way that I'm operating here, and seeing good patient results. So when a patient walks in or somebody tells me, first off, I ask the patients if they're ill to give me a call, and we've been doing that long before COVID, because it makes sense, right? If somebody is sick, especially in our busy athletic training rooms, we don't necessarily want to bring folks in who don't need to be in at a time where there's high volume. So if we still need to see them in person, if a telehealth or a phone visit isn't sufficient, then let's coordinate a time where they can come in where there's not as much volume, where we can be in our appropriate PPE, they can be in their PPE, and so to mitigate any potential spread. But really, the things that go through my mind are, first, what are my red flags? I will want any do not misses, right? Things where this person needs to be referred to the emergency department or to urgent care immediately because of some of the things that they have said that they have. Other things, want to make sure that I don't miss, meaning I don't want to just hear about folks' symptoms if I'm not 100% sure about what's going on without a full evaluation. So yeah, okay, you're saying that you're having a little bit of sore throat, but you have allergies, but it's only one-sided. Things like this, making sure that I'm not missing that peritonsillar abscess and just telling them that they have postnasal drip, right? So just understanding what the big red flags would be, and mapping that to the age group and the factors of the college patient that I typically see, and knowing what our the likelihood is, right? Somebody tells me this year that they have nasal congestion, a little bit of a cough, and a runny nose. I may be thinking a little bit differently than I did in 2019. That doesn't mean that I'm necessarily ruling out the flu or rhinovirus or common cold, right? But it does mean that the prevalence rate of COVID is so high in some places right now, over 41% positivity rate. It makes me think, oh, well, then I really need to make sure this isn't COVID, versus saying, yeah, that's definitely. So all of that sort of stuff mapped together really goes into to how I approach patient care and how I approach making a decision about that. I think the other thing too that's important to think about is what our interventions are going to be, right? And when and how we need to evaluate patients. I just told you that sometimes I talk to patients on the phone and I say, and I give a treatment plan over the phone. However, sometimes we need to do some point of care testing, and understanding when the point of care testing is, and or what the medications to be to treat that when they're in their best window. What I mean by that is, think of somebody that has the flu, right? We often have heard of Tamiflu, right, as an antiviral that we can use for folks that have the flu. Well, knowing that Tamiflu works best in the first 2 days, first 48 hours after symptom onset with a patient, means I know that I need to bring somebody in who has flu-like symptoms, if I'm concerned that it's the flu, to test them early, not to let it go for 3 days, because that's a very vital piece of information to know if we're going to hope to get them on medication. We also know that Tamiflu may only shorten symptoms by a day to a day and a half. But when you talk about anybody in our patient panel, a day to a day and a half, whether they be an athlete, whether they be a soldier, whether they be a worker on the floor, whether they be just a student or anybody in between, a day and a half can actually make a big difference in people's lives. So understanding diagnostics needed because of the potential therapeutics that will be used is very important as well.
Yeah, and you mentioned kind of some of that point of care testing, right? And just I want to go kind of like pre-COVID, right, a little bit, because right now I almost feel like COVID is you know, someone comes to you with symptoms, they're going to get tested, much like anybody during a football game comes to you with a headache, right? Like,
Right.
it's
Yeah. Yeah.
concussion until proven otherwise. I feel like COVID is too, but I guess in kind of that strep throat, right? Kind of looking at some of the clinical tools that you can use to help dictate how you're going to treat people. Do they need to go into a physician clinic? Things like that.
Yeah, I think you make a good point. I mean, especially in today's era, but in our population, in the adolescent population, pharyngitis or sore throat is in our population specifically, it's second behind STI concerns for the college patient. However, so it's very prevalent. We see a lot of complaints, major complaints of sore throat, and strep throat in the college population is still something that is very widespread. Mostly strep A, but also strep C and G. And so again, in this area of opportunity to ensure that we don't bring folks in that are ill, we have to look at how we can do that via telemedicine or via the phone. But the beautiful thing about strep throat specifically is that there are clinical prediction rules we can use to figure out basically whether the likelihood that somebody has or doesn't have strep throat. One of those being that we use a lot here is the Centaur criteria. There's several others that are out there. Just need to make sure they're validated in the population in which you're going to use them. However, the modified Centaur criteria or the Centaur criteria are another one that is used commonly is the fever pain scale. But what that does is it allows us to use an algorithm based on patients' symptoms and signs to determine their likelihood of strep throat. And knowing that if a patient has strep throat, getting on antibiotic treatment early certainly can help decrease the symptom burden of the patient, but also return them to activity. As soon as patients are on antibiotics that have strep throat for 24 hours, as long as they're afebrile, they can return to activity. So being able to diagnose that earlier. For example, let me say a patient walks in at 9 o'clock in the morning or gives me a call at 9 o'clock in the morning, say I have a really sore throat, really swollen glands. I can do a telehealth evaluation with them, determine what score they meet on the Centaur criteria, take that score and look at the rubric and determine, oh, this patient is a 4 on the Centaur criteria. It's 51% chance or greater than 51% chance that they have strep throat. So we need to treat them empirically. I pick up the phone, call our team physician, let them know that the patient doesn't have any allergies, and by 9:30, that patient has a prescription versus waiting to schedule them with that physician who has an appointment at 3 o'clock in our clinic that afternoon. So it also helps eliminate the folks who don't necessarily need to be seen in clinic. We can mitigate those things. Like, oh, you don't have, you have absolutely 0 on the Centaur criteria. This looks to be more viral than it does bacterial, and therefore you don't need to come into clinic. And doing that, just in the first year, we did a little quality improvement project here at BU. Just in the first semester of doing that, we were able to free up 15% of our clinic space that our physicians saw over the course of that semester, which meant that more patients could be seen and patients were still getting high quality patient care. And that's just with strep throat. I think when we're looking at it, we all know about the Ottawa ankle rules, the Ottawa knee rules, Canadian C-spine rules. So using the Centaur criteria is no different. It's a clinical prediction rule that we can use, and just building that in with our team physicians and or our other medical providers whom we work with. I think a lot of times folks think, oh, well, what is an athletic trainer going to do? We can't prescribe medication. We can't, if somebody has strep throat, they need to see the doctor anyway. It's absolutely not the case. Depending on the standing orders we have and what our relationships are and how our physicians and our other providers of whom we work with, whatever plan we've developed, we can certainly be able to do that.
Yeah, absolutely. I think that's a great point, and I love that QI project that you guys did to really show how much space that's able to free up, right? Because like I said, I think it was a black box, right? It's just like, oh, you come to me with these kind of symptoms, I'm just going to refer you. But, you know, not kind of thinking about the ripple effect that that has with everybody else. So being able to free up that space, I think is huge.
Yeah,
Now,
oh, sorry, I didn't mean to cut you off. I was just saying it's a little old now, but there's some data that was in the Athletic Training Education Journal from 2014, and basically one of the reasons why athletic trainers refer folks who walk in with illness a lot is because they don't feel comfortable with their evaluation skills and techniques. And skill decay is true. I mean, if we don't put a stethoscope on folks and listen to lungs, we don't auscultate all of the time, then yeah, we may have a little hesitancy in terms of saying, oh, did I really hear something or did I not? The beautiful thing about that is I'm not asking for folks to figure out what type of murmur we're looking at, or listening for, right? Or what type of crackles or rails or exactly which lobe we're listening in. But what I'm asking is for people to be able to recognize, oh, this doesn't sound normal. And by listening to thousands of normals, we know what's not normal. And that's the thing that I think athletic trainers certainly need to be able to do.
Yeah. Just like with an ACL, right? Even if, or with any kind of knee, any evaluation I ever did on a knee, I checked the ACL regardless, so that okay, what does normal feel like? And that was drilled into my head in school. And I think it's the same thing that you talk about with, with stethoscope, otoscope, everything. Just use it so that you know what normal is. That's a great point. Do you feel like, I think I know your answer based off of, what you talked about, the clinical prediction rules, but do you feel like you're able to get the same level of patient care and clinical outcomes if you're just doing like a phone triage versus, getting your hands on somebody and doing that evaluation?
Absolutely. I think that there is a decision to be made about at what point in time I need a physical evaluation, right? And I think some of that is what would help inform my decision making in terms of, do I need a diagnostic tool? Like, for instance, am I going to do a rapid flu test, right? Am I going to do a rapid strep test? Am I going to do a rapid mono test? Am I going to take we're all familiar with the PCR swab now, but there's a respiratory profile PCR that we like to do that checks for a whole host of viral illnesses. And in the pre-COVID era, just understanding that you had a virus was good enough. But now having a definitive diagnosis certainly is important as well. So I think that for the most part, yes, we can certainly be able to get the information that we need to be able to deliver appropriate patient care and at least formulate a plan moving forward through telehealth, through telemedicine. Yeah.
Okay. And now I'm going to get a little bit prospective here, I guess, but how do you see kind of COVID now factoring into how we're treating patients with symptoms like these in the future, right? Because I don't think we can, anytime somebody comes to you with a runny nose, I don't think you're going to do a PCR test on everybody that walks through the door, right? So kind of how do you see that influencing all of this in the future?
Well, you're right. I mean, it's like when you're a hammer, everything looks like a nail. You know what I mean? And that's sort of how we are with COVID right now. It's like somebody has a stuffy nose and you have to be tested for COVID. And it's like, well, why don't we talk to them about their allergies? Why don't we talk to them about their kid from California, Southern California, who's in their first winter in Boston? I bet you their nose is running. You know what I mean? I think that there's a bunch of things that we have to factor in and be clinicians. Athletic trainers have to be clinicians. One of my good friends, and probably yours too, again, from upstate New York, shout out to Eric Gann, used to say this all the time, is that athletic trainers are clinicians, not technicians, meaning that we have to be able to synthesize all of the data and all the information we have and make a clinical decision due to clinical reasoning. So there will be folks that I evaluate that have a runny nose and they need to be tested for COVID. And there's some that I evaluate that have a runny nose that don't need to be tested for COVID. And all of that is about their own individual circumstance. So we need to treat the patient in front of us and then use our knowledge, skills, and abilities. I think, like I talked about a little bit earlier, if the positivity rate or the prevalence of COVID is extremely high in an area, then that may sway me to test for COVID. But if we get back to how we were this past summer, I'm probably thinking that there's other pathogens that we need to be looking out for, because one of the things that we can't do is put our blinders on and think that flu, RSV, and all the other viruses that are going around just aren't here, because those too can have effects on patients. We hear about long COVID, or we hear about all these other things specific to COVID, but all of these other viruses have been around a long time, and we've seen those also have effects on patients long term. So it's important that we don't miss those too.
Yeah. Well, as always, I appreciate your time. I know you're incredibly busy, coordinating all of, those 40,000 PCR tests. But I want to thank you for just taking the time to speak with us today. I hopefully everybody learned a lot. I know it's good information for me. And as athletic trainers continue to expand their role within the healthcare team, I think your strategies can certainly help improve what we're all doing at the point of care. So thank you for all of that. It's much appreciated.
Well, I appreciate it, and thanks for having me back on. And look forward to maybe talking about a topic post-COVID sometimes.
That would be great if we could get into something else. But we'll definitely talk again in the future, Drew. Thanks again.
All right, thanks, Josh. We'll talk to you.
All right, bye.
Bye.